Hey there, my name is Dr. Topher Fox, and I'm an endocrinologist, and this training is going to talk about Graves' disease, a specific flavor of hyperthyroidism, as well as hyperthyroidism in general. And the goal here is to give you enough information, to give you a lot of basic information about hyperthyroidism, how it's diagnosed, how it's treated, how the thyroid physiology even works so you can understand your testing. And my hope is that by watching this short training, when you and I have a chance to sit down and meet for the first time, that we will be able to function at a much higher level at our visit, that a lot of the basic questions will be answered, and that means we can really spend time and zero in on those specifics that are of interest to you and your circumstances in your life and your particular values and preferences. So with that as an intro, I am going to make myself a little bit tiny here and jump behind the slides. So again, let's just dive right in because we have a fair amount of information to go through. So again, we're talking about Graves' disease and other causes of hyperthyroidism. And here's what I'm hoping that we can cover. We're going to go through just some basics about thyroid physiology. We'll talk about the causes of hyperthyroidism, including Graves' disease, how these are diagnosed, and then we'll talk specifically about the treatment options for Graves' disease and the treatment options for other forms of hyperthyroidism. And then we'll wrap up, and then hopefully I'll get a chance to meet you shortly. So when I think about thyroid problems, I like to break them into two different categories of problems. So we can talk about functional problems. This is where the gland might be overactive or underactive. We can also talk about structural problems, where the gland has an unusual shape, size, lumps, or bumps. And people can have functional problems or structural problems or both. And then obviously if your thyroid is healthy, you will have neither. And so we're going to focus in this training on the overactive thyroid. There are some other trainings that talk about hypothyroidism or thyroid nodules, and so do check those out if you need to. So the thyroid gland, how does the physiology work? We all have a thyroid gland, or in theory we should have a thyroid gland, little butterfly-shaped gland that lives here in the bottom of the neck. And the thyroid gland makes two hormones. They go by the names T4 and T3. T4 and T3 just have to do with a particular molecule that has some iodine atoms stuck on it. And so T4 has 4 iodine atoms. You have an enzyme in your body that can pull one of those iodine atoms off and convert T4 into T3. And T3 is the main active hormone at your tissue level. And all your body's tissues respond to thyroid hormone in some fashion, but especially when we start to think about things like muscle or heart or brain, these all are responsive to thyroid hormone, meaning thyroid hormone influences how those tissues are functioning. Now, back behind your eyeballs, under the front part of your brain, there's a small gland called the pituitary gland. It's one of my favorite glands. It's called the master gland, and it controls a number of your body systems. But for this talk, it makes a hormone called TSH that regulates your body's thyroid function. So your thyroid gland can actually sense how much thyroid hormone is in your bloodstream, and it can regulate that TSH, trying to keep the levels appropriate. So it's kind of like how the thermostat and the furnace work in your house. If the pituitary gland senses that the thyroid levels are too high, that the T4 and T3 levels are too high, it will reduce that TSH, trying to tell your thyroid, hey, you don't need to make so much thyroid hormone. And so that means, somewhat confusingly, I think when people are getting used to thyroid physiology, that when the thyroid becomes overactive, when T3 and T4 levels go up, TSH goes down. And this is true under all circumstances where the pituitary gland is functioning normally. So you can think of TSH and T4 and T3 being on a seesaw. They tend to go opposite directions of each other. Now, when we think about what causes hyperthyroidism, or what causes high thyroid hormone levels, and there's a little bit of semantics here that we don't have to get into. We're going to use the term hyperthyroidism to mean too much thyroid hormone in your blood. which is not 100% correct, but it's really close. Very common thing, probably the most common thing that we diagnose is a condition called Graves' disease. We're going to talk about that here in a minute. There is another condition called thyroiditis, inflammation in the thyroid gland, that has three particular forms: subacute thyroiditis, silent thyroiditis, and postpartum thyroiditis, that all have this characteristic pattern of causing overactivity followed by underactivity. Now, some people have what we call toxic thyroid nodules or autonomous thyroid nodules, or you'll hear this term hot nodules. These are nodules that make too much thyroid hormone. And then a very common reason that people have too much thyroid hormone in the blood is that they are taking thyroid hormone and their dose is a little bit too big. And so we're not really going to focus in on that one for this talk. Obviously, there would be a call in that situation to adjust the dose of thyroid hormone appropriately. So what happens in Graves' disease? Well, what we know is in Graves' disease, it's an autoimmune condition, meaning the body is able to react against itself. The immune system says, hey, that's not supposed to be here, and mounts an attack against part of the body, in this case, the thyroid gland. And what we see in Graves' disease is that there's actually an antibody, a specific antibody that is made that looks like TSH to the thyroid gland. So if we test this in the blood, typically we'll measure what's called TSI, or thyroid stimulating immunoglobulin, or TRAB, thyrotropin receptor antibody levels. These antibodies are like a counterfeit key. They are able to tell the thyroid to produce thyroid hormone. But unlike the TSH, which is closely regulated by the pituitary gland, this antibody is just being produced, and so the thyroid is receiving a continuous go, 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 go signal. And generally, we need to do something in order to treat that. We'll talk about that here in just a moment. Now, just for completeness, let's run through a couple other reasons why the thyroid hormone levels can be high. So in thyroiditis, what we see is there's actually an acute damage to the thyroid gland. So think of the thyroid gland with thyroid hormone stored inside like a leaky water balloon. Well, the thyroid normally is just a regular water balloon. The damage causes it to be a leaky water balloon. So there's damage to the thyroid gland, and that damage allows thyroid hormone, which is stored in there, to come leaking out into the bloodstream. Now, what we see in this situation is that typically, as I mentioned, the thyroid will do this thing where it goes overactive, and then quite often it will go underactive, although some people will go overactive and then come straight back to normal. And for people who go underactive, usually it comes back to normal, but there are some people who swing low and stay low. And each of these phases, the overactive phase and the underactive phase, will last for about 2 to 3 months. Okay, last thing I'll talk about here is this thing called a toxic thyroid nodule. So in this situation, there is a nodule in the thyroid gland, a little bump in the thyroid gland represented by these blue dots. And what we find is that most nodules, so the vast majority of people who have thyroid nodules, do not have toxic nodules, hot nodules, autonomous nodules. They have what are called cold nodules. But a small percentage of nodules do actually overproduce thyroid hormone. We call those toxic nodules or hot nodules. And I like to think about them kind of like a rebellious teenager. So I'm a parent of 2 teenagers right now. And the rebellious teenager basically stops listening to that normal signal, the TSH signal, and it just produces thyroid hormone all the time. So it says, I'm going to do what I want. I'm going to make too much thyroid hormone. And so we see those nodules actually overproduce thyroid hormone. Okay, deep breath here. So what are symptoms of hyperthyroidism? So there's a long list of symptoms: fatigue, weight loss, feeling hot all the time, shaky or sweaty, heart racing, irritable, anxious. Sometimes people will feel a little breathless with exercise. For women, the menstrual cycle may stop or reduce in frequency. And one of the things about all of these symptoms is they're what we call non-specific symptoms. This simply means that they're not specific for the thyroid. So many people can have similar symptoms. If we think about somebody who has an anxiety disorder or somebody going through menopause, a lot of the symptoms will overlap or be the same. Now, there's a little asterisk there by weight loss just to say about 10% of people with hyperthyroidism actually gain weight, probably through stimulation of appetite. And then finally, there are a couple symptoms that are not directly related to the hyperthyroid, but that I would be curious to know about. One would be problems with the eyes, if the eyes have become more prominent or there's any double vision or eyeball pain. Sometimes these can be seen as a sort of separate manifestation of this condition called Graves' disease. And then there are some flavors, one flavor in particular, subacute thyroiditis. There are some flavors of thyroiditis that can be associated with pain on the outside of the neck around the thyroid area. And so the diagnosis of hyperthyroidism generally is made through a combination of compatible symptoms and supportive blood test results. So compatible symptoms, we test the blood and we find the blood supports that the thyroid hormone levels are too high. Now I'm going to show you this, and this will be relevant when we talk about treatment, which is we think about compatible blood tests for most people is going to be a low TSH. And again, if there's some reason why the pituitary gland is not working, like a pituitary tumor or pituitary radiation, then this won't hold true. But when the malfunction, so to speak, is at the level of the thyroid, we'll see the TSH will be low, and then the T4 and T3 will either be elevated, might be one or the other that's elevated, or they'll be at the upper end of the normal range. And what we see is that the TSH level, normal goes from about 0.4 up to 4.5. And if we think about people that are higher than 4.5, the TSH has gone up. Generally, that's going to be associated with hypothyroidism. And I like to draw this little line here around 0.1, just to say if the TSH level is low, but somewhere between 0.1 and 0.4, this is what we would call mild hyperthyroidism. It's kind of like driving a car 60 miles an hour in a 55 zone. And in general, there's an option to treat in this circumstance, but we don't necessarily treat 100% of people in this situation. Now, typically, if the TSH is below 0.1, then most of the time, I'm going to recommend treatment for most people. Now, you as the captain of your own healthcare ship, the captain of your own body, obviously get to make a choice. And whenever we talk about treatment options, the idea to say, well, I'm going to do no treatment, of course, is always an option. But I want to make sure you have all the information to be able to make an informed decision if that's the direction that you decide is appropriate for you. And the concern with low TSH or untreated hyperthyroidism is that it does put a stress on the skeleton. So we see an increased rate of bone loss, and we see an increased rate of irregular heart rhythms and heart stress. So a heart rhythm called atrial fibrillation is more common in particular, and sometimes we see the heart muscle will actually thicken and enlarge when people have untreated hyperthyroidism. Okay, determining the cause of hyperthyroidism. In general, there's going to be symptoms and physical exam, and if the thyroid gland is tender, that might suggest thyroiditis. If it has lumps in it, that might suggest nodules. Often people with Graves' disease may have changes in their eyes that are visible, or the thyroid just may be diffusely enlarged, kind of swollen, what we call a goiter. Obviously, we can do blood testing. For Graves' disease, we can measure those antibodies that I mentioned, the TSI and the TRAB antibody. We can do a thyroid ultrasound to look for nodules, and sometimes distinguishing Graves' disease or thyroiditis, we can actually use the ultrasound to look at blood flow, which can be useful to help us distinguish. And then there is a test that we do, not all the time, called the thyroid scan and uptake, where you swallow a little bit of iodine and then come back and get pictures taken 6 hours later and 24 hours later to look and see where that iodine went. Can help distinguish between Graves' disease and thyroiditis, or it can help determine if there are thyroid nodules, which ones, if any, are the rebellious teenager, the hot nodule. But again, all of this will be tailored to your particular circumstance. Okay, in the last few minutes, let's just run through treatment options. So for Graves' disease, we have 3 primary options: antithyroid medication, surgery, and radioactive iodine. Antithyroid medication, almost all of the time we use as the preferred agent one called methimazole. There's another agent, PTU or propylthiouracil. PTU was used for a long time, but it turns out it's associated with, uncommonly, people can have severe liver reactions to this. And for that reason, we tend to use it only during the first trimester of pregnancy. And that's because methimazole has a rare side effect or it can affect the baby's skin development during pregnancy. So again, anti-thyroid medication, in general, we're going to use methimazole, but for women, if you are pregnant or if you become pregnant while on methimazole, we want to do a little switch to make sure that we are treating you appropriately. Now, methimazole and PTU both have uncommon side effects, so about 5% of people might notice a rash or joint pain or muscle pain or itching. And there's this very rare reaction that we worry about. It happens to about 1 person out of 300. So I think I've now seen it 2 or 3 times in a 20-year career. It's very, very uncommon, but it causes people to stop producing white blood cells. And it turns out white blood cells are very important. They help your body fight off infection. You need white blood cells. And this reaction almost always shows up with a fever or a bad sore throat. And that means if you're taking methimazole or PTU and you have a fever or a really bad sore throat, we have you temporarily stop the medicine, give us a call, and we want to check your blood and check your white blood cells to see if they're okay. Now, most of the time, sore throat, fever, you're just getting a cold, your blood's fine, and you go right back on the medicine when we get the test result back. If we do see those low white blood cells, they do come back when we stop the medicine, but sometimes we need to support you with antibiotics, observation, sometimes even bring folks into the hospital during that recovery phase. Now, the dose of methimazole is typically adjusted based on your symptoms and your blood test results. So we usually need to start with a higher dose in order to get the thyroid levels to come down, and then we need to reduce the dose to find the appropriate dose that just keeps you at the right level, not too low, not too high. So typically blood testing might be done every 4 weeks initially. Over time, that stretches out maybe to every 3 or 4 months. If your thyroid does dip too low, constipation, fatigue, weight gain, muscle pain, these might be symptoms that would show up, and so certainly we want to know if those are developing. Now, with anti-thyroid medication, the goal in general is to try to treat people for about 18 months. And what we find is that after 18 months, about 30% of people, so almost 1 in 3, will achieve remission, which means we can stop the medicine and the overactive thyroid doesn't come back. Now, that means for 2/3 of people, the overactive thyroid does come back, and we have to make a decision about whether to go back on the medicine or whether to switch to surgery or radioactive iodine in that circumstance. And as we assess for remission, often we'll measure the TSI or the TRAB level to look at what's the likelihood of success. And then finally, for pregnancy, as I mentioned earlier, we do, during that first trimester, switch off of methimazole onto PTU and then generally back to methimazole for the second and third trimester. We do try to treat the levels a little bit differently, so we like you to be a little higher, to leave you a little higher functioning during pregnancy. And it turns out the Graves' disease antibody can cross the placenta. So it is important for your pediatrician and your OBGYN to know that you have Graves' disease and just beware of that potential for that antibody to affect the baby's thyroid function. When that happens, it's most commonly a temporary thing, but important for the doctors to look for. Now, radioactive iodine sounds scary. Radioactive anything, right, sounds a little bit scary. Been around since about 1940 or 1950, long track record of safety. The basic idea is you swallow a little bit of iodine that's got some radiation attached to it, and that allows it to get concentrated in the overactive thyroid tissue and ultimately to destroy that tissue. So it's very safe, it's very targeted for the thyroid gland. Because that radioactive iodine can show up in breast milk or can affect the baby, we don't use it if you're pregnant or breastfeeding. And for people who have that eye disease I mentioned earlier with Graves' disease, if you have significant eye problems, radioactive iodine can make that worse. And so we generally don't like to use it in that circumstance. Now, the expectation when we give it is that you will develop hypothyroidism, low thyroid function, and ultimately need to go on medication that would then replace the thyroid hormone that your body needed. Surgery can be used. Typically, the surgeon will take out the whole thyroid or most of the thyroid, what's called a total or near total thyroidectomy. And again, this results in low thyroid function. And typically we need to use the medication, the anti-thyroid medication, in preparation for surgery so that your levels are normal or near normal at the time of the operation, just so it's safe to have anesthesia. and go through the operation itself. And then finally, there's a type of medicine called a beta blocker, which is kind of like a symptom control medication. It can slow down the heart rate or reduce shakiness or sweating. So we use this for people who have significant symptoms who need a little help until one of these other treatments is effective. Beta blockers not generally used in people who have asthma, or we have to be careful in that situation because it can make asthma worse. So again, this is a treatment-focused, a symptom-focused treatment that not everybody will need. Now, as I mentioned, I wanted to conclude, well, let's go back. So Graves' disease, when we think about the treatment, really the choice for most people comes down to the anti-thyroid medication versus the radioactive iodine, unless you've done research and you really want surgery. It's usually one of those two. And they're both good treatments. It really depends on your values and maybe a couple other circumstances. And so we can chat about that when we get together. Thyroiditis, as we wrap up, I'll just talk about the toxic nodule and thyroiditis. So again, this is that overactive, underactive loop. What we see is that if you have a painful condition, subacute thyroiditis, that non-steroidal anti-inflammatories like ibuprofen can be effective for that. In more severe cases, we use prednisone, a steroid medication to control that, usually just needed for a few weeks. The hyperthyroid phase typically will resolve on its own with time. Many people don't need any treatment, knowing that it's going to get better. If we do use a treatment, typically it's going to be one of those beta blocker medications. And for the hypothyroid phase, again, because it's short-lived and mild, many people don't need any treatment, but we do have the option to temporarily use thyroid hormone if the low thyroid symptoms, fatigue, cold intolerance, constipation, muscle pain, if these are particularly prominent, we will often use thyroid hormone for a period of 3 to 6 months and then think about stopping it to see if it's still needed. For toxic thyroid nodules, hot nodules, those rebellious teenagers, for mild disease, we often will simply monitor. We have really the same options, radioactive iodine typically being preferred, and the rate of low thyroid function in this situation is much lower. Maybe only about 1 out of 3 people will develop low thyroid function, so the majority will return to normal thyroid function. We can ask a surgeon to take out the overactive nodule or nodules, and we do have the option to use the anti-thyroid medication. In this situation, there's no expectation that remission will occur, so we would think about those medicines typically being a lifelong treatment in that option. And then an up-and-coming treatment is something called radiofrequency ablation, where using a needle, a small amount of heat can be injected into the center portion of the nodule to try to shrink that nodule away or destroy that nodule or most of the nodule. And it looks to be a promising new therapy for toxic nodules, particularly if there's just one toxic nodule. So we've covered a lot. Thyroid physiology, what causes hyperthyroid, symptoms of hyperthyroidism, how we diagnose it, the treatment of Graves' disease, treatment options, and treatment for other hyperthyroid conditions. And so with that, I am going to wrap up and just say I look forward to meeting you at our first visit. Do me the favor of making sure that you get your 2 forms, your medical history form and your registration form in. That'll just, again, help us to be able to focus most specifically on you and what you need and what your questions and your goals are during the time that we have together. And until I see you, I wish you peace. Take care.